how can we balance the priorities between acute and long-term needs in relation to choosing antipsychotics?
That's difficult because the doctors that take care of you acutely are not the doctors often that take care of you chronically. And the acute doctors want to pass the buck on to the chronic doctors because it makes their life easier to use one or two well-known drugs that are inexpensive and work well, and more or less either dump the patient or transfer them, be a more delicate way of saying it, into another sector, and now it's your problem. And so the poor person in the outpatient setting is inheriting a patient on a high-risk metabolic drug very often, and you have to watch this patient. If they're beginning to gain weight and have metabolic syndrome, you have the dilemma. If the patient is doing well in terms of their psychosis, do you want to jeopardize the possibility of making them worse and getting them rehospitalized for the sake of making their metabolic syndrome better? And if the patient is somewhat less than ideally managed, it's an easy decision. Or if they're beginning to decompensate and you need to raise the dose or switch the drug anyway, you might as well switch it to a metabolically friendly drug, and that's not a problem. The problem comes when it ain't broken, you don't want to fix it. And so there is that mentality, but over only so long can you go if the patient's gaining weight. At some point your hand is going to be forced. And probably the trigger point is prediabetes. Probably the trigger point is going from being overweight to obese. If the patient has progressively gone, in terms of having their blood's looking bad, but now all of a sudden they have prediabetes, and they also then have some of the metabolic syndrome developing, including obesity, shame on you if you don't change the drug. So switching in the outpatient setting is a balance. And I can tell you it's a lot better to prevent the metabolic syndrome than to cause it. Let's put it this way as well. How about doing the "it's my son" test? So you want to hear that your son with schizophrenic is going to get the cheap drug that's easy to use because the doctor finds it useful. And then when he becomes a diabetic and going to die 20 years earlier, we'll start thinking about taking care of him. That's not the way you'd want your son treated. And so part of the issue is if you're forced to use certain drugs in the hospital because of payer mix and tradition, then it's incumbent upon the people in the outpatients to know that there's a range of drugs that could potentially have your cake and eat it too. In other words, keep you out of the hospital, have adequate antipsychotic control, and still not cause metabolic syndrome.